is entitled to not fear for her life when conceiving a child and giving birth to that child.
Every day around the world, every 90 seconds, a mother dies giving birth.
In Africa, women are dying of causes which could have been prevented. No woman should die of anemia. They should not be getting lacerations and fistula. The Somali woman has one of the world's highest maternal mortality rates. She's been ill for 3 months. She should be in hospital. We need highly trained, scientifically trained midwives. With the minimum that we have here, we can save 3 out of every 4 women who would have died of maternity-related causes. You can save lives. And when mothers are saved, babies are saved. When babies are saved, families are saved. It's saving the pillar of that family, women.
Although in recent decades, child mortality around the world has generally decreased, problems with maternal health have unfortunately remained the same. As a result, the lack of healthy mothers continues to jeopardize solving other major problems such as infant deaths. Specifically, each year, more than 500,000 women die in childbirth or from complications during pregnancy. 99% of maternal and newborn mortality occurs in the developing world, due to the fact that over half of the women who deliver babies still do so without the assistance of skilled health personnel. For example, in Uganda, only 38% of women deliver at health institutions under the supervision of trained and skilled health workers. Around 80% of maternal health-related deaths are caused directly by obstetric problems, or the care of women during and after their pregnancy related to their reproductive system. For example, many women face infection, complications of unsafe abortion, and other hypertensive disorders of pregnancy, such as high blood pressure. While almost all deaths related to pregnancy problems are recorded, the issue of maternal health is so large because for every woman who dies from complications related to childbirth, approximately 20 more suffer injuries, infections, and disabilities that are usually untreated and even ignored. Maternal health, or in this case, the lack thereof, results not only in physical lifelong pain for women, but also causes social and economic exclusion, as many in these societies view females as worthless if they are unable to reproduce and be obedient to their orders. Due to the lack of advanced technology, as well as the lack of increased funding, and just an overall attitude of indifference to women's health in underdeveloped countries, maternal health-related complications cannot be prevented nor predicted. Particularly, the problem of maternal health has been broken down into 4 major factors, including biology, lack of schooling, lack of rural health systems, as well as the outright disregard for women. With education, families are more likely to earn a living, accumulate savings, ultimately be able to afford health care and plans for healthy pregnancies. Furthermore, the lack of supplies, untrained professionals who work long hours, and a shortage of qualified doctors contribute to the maternal health problem. Although governments are aware of this problem, maternal health issues are not addressed due to the underlying idea of gender inequality. Like many other problems, maternal health is continuously referred to as a women's issue, and thus not given funding or the attention required to combat the issue's existence. Previously, as late as the 1920s, America had a maternal mortality rate equal to the extremely poor parts in Africa. Shortly after, deaths of women in America related to pregnancy began to drastically decrease. This was due to better antibiotics and research, but mostly due to female suffrage. It is obvious that in order to improve maternal health, women need better medication and medical attention, but most importantly, they need to be looked upon as equal to men. Once their lives are viewed as important, maternal health will increase as they finally receive the services needed to be healthy during and after the pregnancy process. Altogether, the lack of investment in medical resources and cultural expectations of women during childbirth and post-labor pose extreme threats to the health of the mother, the girl child, and the community as a whole.
Although the adverse effects of maternal health are harmful to all women, adolescent girls are particularly affected by childbirth. In India, about 40% of adolescent girls are married before the age of 18, at a median age of 16 years old. Newly married girls leave their natal home in order to take up residence with their husband's family, where they quickly begin childbearing. Indian women often do not use available services for family planning, contraceptives, or the birthing process. Several studies have documented a greater inclination to seek curative care, but relatively low use of preventative services. Sexual matters and related gynecological problems are shrouded in a culture of silence, embarrassment, shame, and blame. In many parts of India, other family members dictate whether a woman's condition warrants treatment and what type of care she receives. In a study of 100 pregnant women in Uttar Pradesh, 56% deferred decision-making about health issues to their mothers-in-law, and 15% to their husbands, leaving only 29% of women making their own decision regarding their health. Unfortunately, the majority of these women are illiterate and lack the ability to make any sort of educated decision regarding their medical well-being. The data found in these studies points to a need for a systematic process in which young women are given the opportunity to empower themselves and make their own medical decisions. The first step begins with the symptom being identified by the girl, creating a felt need for treatment, telling a family member, agreeing that the problem is worth taking action, and seeking treatment. Many young brides often feel that any relaxation from the domestic routine is an ill-afforded indulgence. Mother-in-laws strongly object to any delay, and the girls are often willing to have a child in their first year of marriage to meet this social expectation despite their medical ailments. By hiding their health issues, young girls often make it even more impossible for family members to become aware of their health problems until they have escalated beyond treatment. Not only are the life prospects of a mother seriously curtailed by becoming an adolescent parent, but the conditions of the offspring to an adolescent mother are curtailed as a consequence of poor maternal health. Indeed, mothers who did not live in poverty were able to offer their children environments with more reading and enrichment. Although the risk of being born to an adolescent mother may be largely due to socio-demographic factors rather than maternal age, mothers and children can nevertheless benefit from intervention. Women are generally more depressed than men, and the consequences wrought by insufficient parental psychological resources are evident in child abuse and neglect in all nations. A few studies of depression have succeeded in obtaining truly representative samples to exhibit that the structure of depression is not constant across the three age groups. This is a reminder that adolescent mothers do not necessarily see the world in the same way as adults do. Adolescents are, as a whole, very naive and shy to acknowledge the problems before and after childbirth, which are capable of resulting in serious medical consequences. A new program instituted in India, the National Reproductive and Child Health Program, includes emergency care and management of reproductive tract infections. Health workers should also work to promote the use of modern-day family planning methods and inform young women of the contraceptive effects of breastfeeding. Community-based education programs for both young women and their husbands would seem appropriate in places like rural India. Finally, it is of the utmost importance that young married girls have the right to make their own decision about seeking treatment for gynecological problems, where they feel that treatment is necessary. This is a matter of social action, and not a matter for health services to resolve.
The current global status of maternal health has not yet seen the improvement desired. Groups such as UNICEF and the World Health Organization have set goals that are not on track and have not yet been achieved. While some progress is always beneficial to the issue, the maternal mortality rate continues to climb and affects several areas of global concern. UNICEF has a target goal to reduce the maternal mortality rate by 3/4 by 2015. This is part of Millennium Development Goals 4 and 5, with the intention of reducing child mortality by 2/3 and maternal mortality by 3/4 from 1990 to 2015. This goal is off its target with some progress, but not nearly enough to reach the goals desired. Today, a woman dies from complications in childbirth every minute, totaling to about 529,000 each year. UNICEF is working to attack maternal mortality through several different programs and initiatives. Malaria has become another large risk to expecting women, as it can lead to anemia. Anemia is a dangerous condition where iron levels in the blood are low. This severely increases the risk for maternal and infant mortality when iron levels become too depleted and there is significant blood loss during pregnancy. In order to prevent malaria and thus decrease the risk of anemia, more bed nets need to be provided to help expectant mothers avoid malaria, and malaria treatment needs to be made more accessible to treat affected mothers. Besides malaria, HIV is an even greater risk to expectant mothers, contributing largely to the maternal mortality rate in southern Africa. Up to 45% of HIV-infected mothers end up transmitting it to their children, causing greater health risks to already disadvantaged kids. By increasing awareness and education, UNICEF hopes to reduce these numbers in the coming years. Only 17 countries are currently on target to reach their goal, and despite the increase in skilled birth attendants at deliveries from 43% to 52%, only 5% of this is attributed to sub-Saharan Africa, where maternal health is the largest issue. UNICEF has worked to develop programs to decrease anemia and help get girls in school. It has provided tetanus immunizations for pregnant women and supplied micronutrients to women with anemia. UNICEF works to encourage young mothers to allow their children the basic school education, which in turn benefits future maternal health by educating girls and helping them to rise out of poverty. While the World Health Organization works to improve maternal mortality rates in all aspects, its largest program is the prevention and treatment of syphilis. The WHO attributes syphilis to the cause of most maternal deaths and problems in newborns. It estimated that 650,000 fetus deaths occur because of syphilis every year. The WHO states that prevention costs are low, at only $1.50 a person for testing and treatment. One of its main and most important goals in improving maternal health is to eliminate syphilis by up to 80% by 2015, under the Global Elimination of Syphilis Initiative. There is a specific 5-year plan which focuses on 10 countries most severely affected.